Thank you, Dr. Dawson. Dr. DeAngelis?
Thank you, everyone. I think really what I'll end up saying is perhaps a bit of overlap, or it has already been mentioned, but I will go ahead nonetheless. I think I started looking at this and thinking, well, what would be the ideal medication to try to help chemotherapy-induced peripheral neuropathy? And really the ideal medications that we would like to see or would used are medicines that obviously work in preventing or lessening the symptoms that a woman would experience from their chemotherapy. We also want to make sure that that drug or that does not interfere with the anti-cancer therapy. And this is a very important point because there have been certainly attempts in the past, as Dr. Dawson has mentioned, there is a fair bit of research. There have been attempts in the past with various medications, and some of them have not gone forward because they seem to affect the outcome of the therapy. So we want to make sure that these any therapy that we would use in this setting does not interfere with our anti-cancer therapy. And then, of course, the final characteristic or the final property that we would want a drug or a medication to have would be that it wouldn't give any additional toxicity. And unfortunately, I'd like to say that that there is something out there that, in fact, satisfies all these three properties, but at this point there aren't there isn't a medication like that. I did, though, want to review a little bit of you may have, in reading, you might have come across amifostine, and Dr. Dawson did mention amifostine, and the findings in terms of studies when you actually compare a group of women who received the drug together with their chemotherapy versus another group who did not receive the drug, that the findings are inconsistent. And I guess what I mean by that is that some studies seem to suggest that it might help, and other studies suggest not. And when you put it all together, most people feel that it does not help. So amifostine, unfortunately, doesn't appear to be the agent that we're looking for. In addition, again, as previously mentioned, it does have some significant toxicity, particularly nausea, vomiting. It's a difficult drug to give, and you're already receiving therapy that is giving you or maybe giving you other side effects besides the peripheral neuropathy. And again, in this setting, amifostine, there is some suggestion, again, early work that it might be affecting the chemotherapy itself. So I think, in general, physicians and clinicians are a little bit hesitant to use the medication for those reasons. Glutamine, I believe, has been mentioned, and here again, unfortunately, there is no convincing evidence that, in fact, it's useful. The other the other strategy that has been tried for oxaliplatin, which isn't a drug commonly used in ovarian cancer but is related to cisplatin, are infusions of magnesium and calcium, so minerals that are thought to prevent the nerve damage. And here again, unfortunately, in a trial just recently stopped, the infusions seem to, of calcium and magnesium seem to decrease the effect of the chemotherapy. And so unfortunately, it's not that it may not work, but in fact, it may decrease the chance of the success of the therapy. And so it's not going to be pursued any further. There are agents under study, and really two that I'll mention right now. One is called dimesna, which shows very promising animal data. Appears to be safe in humans. There have been studies done to look at various doses and ways of giving the drug, and it seems to be safe in humans. And in some of these studies, they were actually able to look to see whether it was of any benefit. And again, there seems to be benefit in this group of women. It's not the scientific evidence that we would like as healthcare professionals, but at least it looks promising that the women receiving the drug seem to have less peripheral neuropathy and symptoms or signs of peripheral neuropathy than other women that in the past. So we're comparing them against women in the past, but of course the ideal would be to compare them with women that are currently receiving therapy. So from historic controls, it looks very promising, and this drug is moving forward into what we would call phase 3 trials, where it is being compared to no therapy at all. And the last agent I'll mention in terms of new therapies is nerve growth factor. again, found to be useful with cisplatin in animal models, and I think we're waiting now for human studies. It's been tried in other areas besides chemotherapy-induced neuropathy with not a whole lot of success, but the hope is that in the chemotherapy area it might make a difference. So I think, as again Dr. Dawson mentioned earlier, there is a lot of work being done in this area. It certainly is not being ignored by the medical community, and we hope to have agents soon in terms of that will be effective and have all the ideal properties that we're looking for. I just want to finish up with a couple of comments on again, following up on what we might be able to do to manage the peripheral neuropathy. If we can't prevent it, then hopefully we can do something to manage it. And you've already been given very good advice about being aware of the potential for the peripheral neuropathy, to recognize your early signs of something that's changing. So I think that's important to understand, that to be on the lookout for change. Any kind of change, you really need to let the healthcare team know that something has changed and is going on. Because we know one thing, that if we intervene early, that we can make a difference in terms of lessening the symptoms, and in some cases they go away completely. We also can, at that point, delay the therapy or decrease the doses. And there is some evidence to show that maybe slowing down the infusion of the drug may actually prevent the peripheral neuropathy. So it's really important to be aware of what's happening, to let the healthcare team know that something has changed so that we can do something about it. I'll finish off with a couple of comments on managing the symptoms, or in particular the pain. Dr. Dawson mentioned the tricyclic antidepressants, which are very useful. And there's evidence with another drug called gabapentin, and another agent in this a newer version of gabapentin called pregabalin, which has not been studied in chemotherapy-induced peripheral neuropathy, but looks very promising in the area of diabetic neuropathy. And the hope is that these agents can be used to manage symptoms if they reach a point where, in fact, they're debilitating or causing problems for you. But it is very much trial and error. So I'm just going to finish off by saying that there are things that can be done, for example, avoiding cold or sudden chills, like putting your hands in the refrigerator or freezer to take something out. Might be advised to wear gloves or prevent a sudden chill of the hands. In the winter, making sure you're wearing very warm gloves and insulated footwear, and really identifying and avoiding the triggers. It's very important that you are aware of everything that's happening to you with respect to the peripheral neuropathy. And I think I'll end there, and I think Kathy's coming back on.